I'm Dr. Lawrence Chan. I'm a consultant cardiologist in CVSKL. I'd like to thank Docquity for the opportunity to talk to you all about a very topical subject, which is about COVID-19, and in particular COVID-19 with respect to heart patients. The outline of my talk is as follows. We'll discuss general aspects of COVID-19 and then go into the particular pathological effects of COVID-19 on the heart. In particular, the processes of inflammation, direct viral injury, and also indirect stress on patients with pre-existing heart disease. So what is COVID-19? COVID-19 stands for coronavirus disease, which was first reported in 2019. This disease is caused by a new coronavirus, which is now deemed as SARS-CoV-2, SARS standing for severe acute respiratory syndrome caused by the coronavirus type 2. This disease predominantly affects the respiratory system, and the most common serious manifestation thereof is pneumonia. Now, let's look at the data that's been coming out of the relevant countries, in particular from Wuhan, China. There were up to date around in February or early March, 72,000 people were reported to have COVID-19 disease. So these are people who had the virus and had symptoms. Of those who had symptoms, 83% of those who had symptoms, the symptoms were mild. That means they had either no pneumonia or mild pneumonia. But 14% of the patients developed severe symptoms whereby they had hypoxia, they were dyspneic, and more than 50% of lung was involved. 5% became critical with shock, respiratory failure requiring ventilation, and multi-organ dysfunction, and the case fatality rate was 2.3%. In March, in New York City, the statistics were pretty much similar. 12% of patients required ventilation, but of those who required ventilation, the mortality rate was horrendous at 88%. If you look at the patients who were 65 years and above who required ventilation, only 3% survived. So they had a case fatality rate of 21%, but this was this figure of 21% is out of 2,600 patients, because a remainder 2,500 patients still had ongoing treatment. So the actual case fatality rate is not as bad as it sounds. So what did we find? We found that a lot of the patients with severe disease had other diseases pre-existing. So we call those comorbidities. And the more comorbidities there were, the more severe the disease. Again, looking at Wuhan, 50% of patients with COVID-19, those with disease, those who got the virus and had disease, 50% had pre-existing illnesses. If you look at those with severe disease, 72% had comorbidities. So if looking at this slide, the death rate also goes together with comorbidities. The most obvious here is that the older you are, the higher the chance of fatality. If you look at the 80-year-old, 80 plus and above in China, up nearly 15% succumbed. If you look at comorbidities, the most obvious comorbidity that resulted in a poor outcome was heart disease, hence the reason for having this talk. Also, you look at gender, males tended to have a not so favorable outcome, although this apparently is changing, and when you look at Italy, the difference was less. Other health conditions that lead to A poor outcome would be concurrent diabetes, lung disease like asthma, high blood pressure. So this slide shows again that heart disease is among the worst preconditions to have if you're going to have, if you're unlucky enough to get the SARS-CoV-2 virus. So what are the comorbidities? So they are, as what we mentioned, as well, obesity, gross obesity leads to poor outcome. Pregnant women have a poorer outcome. People with asthma also would be at risk. And other things would be chronic kidney disease, vascular dementia, smoking, and as we mentioned earlier, cardiac and cerebral vascular disease. Now, as we showed earlier in the slides from China and also the data from the United States, it's very obvious age is the worst thing for the older a person is, the worse the outcome. So it's a very important factor. If you look in China, very few below 60 years of age succumb. The case fatality rate was 0.3%. Unfortunately, above 60 years old, above 6% of patients did not make it. The same applied in Italy. They look at below 30 years old, nobody succumbed. And above 80 years old, 20% did not make it. Similar things also in the United States. Up to 30% of the patients that succumbed were 85 years old and above. So that is a general overview about COVID-19. What about COVID-19 and heart patients? So let's look at it. Let's break this down. Are heart patients at higher risk of catching the SARS-CoV-2 virus? Well, it's a virus. So the initial theory and clinical thing is that the virus can be caught by anyone. However, as of 6th of May, this became a maybe, that maybe heart patients are more likely to get the virus, whether they are more exposed because they have to access medical care, one is not sure. So what this shows is that our knowledge about the COVID-19 is still evolving and evolving very rapidly. But as far as infectious diseases are concerned, any one of us is equally likely to get the virus, except that if you have illnesses, you're more likely to get the virus and then develop disease. And the more pre-existing diseases you have, the more likely you will get a severe form of the COVID-19 disease. So clinical studies up to date have shown that up to 20% of COVID-19 patients also have heart injury. So not only that heart patients are more likely to get the COVID-19 disease, but also the disease itself may result in heart disease. So there was a publication that the journal Frontiers in Cardiovascular Medicine that proposed 3 different pathological pathways that lead to heart disease. One being the widespread inflammation that the virus stimulates. Then you can have, as a virus itself, you can directly infect and injure cells. In particular, today we are talking about the cardiovascular system. And if you have a pre-existing illness, then if you have heart problems already, any other stressor will make this would put extra pressure on a not so good organ and therefore precipitate things like a heart attack. So let's break this down. So the inflammatory response. So I'll show you this diagram, and what it shows is that the SARS-CoV-2 virus, when it infects cells, it will stimulate the inflammatory response. The body is trying to get rid of this alien invader. So it puts out in intermediaries such as the interleukins and the interferons and the cells, and this sometimes goes to a very high level, and this is called a cytokine storm. It's an extreme amount of inflammation. And sometimes it goes wrong. It not only attacks the virus, but it starts to attack normal cells. So this becomes an abnormal autoimmune reaction. If it affects the heart, it goes to the myocardial cells. It will lead to muscle cell necrosis, heart muscle cell necrosis, and this can lead to fulminant myocarditis, which results in heart failure and heart rhythm abnormalities. And this has been noted both in China and also in the United States, and I guess every other place. So this process has been known to happen before with other viruses. The most common predecessor for this, for a virus to affect the heart muscle and cause myocarditis, is with the Coxsackie B virus. So we do understand that this process occurs with viruses. And what happens in the clinical setting, you can see that the patients would have elevated levels of cardiac enzymes indicating muscle cell damage, abnormalities on the ECG, and on the echocardiogram. So unfortunately, this process can also affect the previously healthy, those without heart disease. So it can result in a viral cardiomyopathy. Now, a subset of the inflammatory response is what I would like to talk to you about as well. This is a process that has been looked at before, whereby the severe inflammatory response affects the plaques in the coronary arteries. So when these inflammatory molecules affect the fatty deposits in the blood vessel wall, which already very often have inflammatory white cells, it can boost the local inflammatory response within the plaque, and thereby causing rupture of the atherosclerotic plaque, which will trigger a heart attack. Fever and inflammation renders a patient's blood more prone to clotting, while interfering with the body's ability to dissolve clots. This will increase also the risk of thrombus formation. So not only would you have a ruptured plaque, but you also could have a thrombus forming on these destabilized plaques. Again, there's a precedent with older research looking at infections with viruses and resulting in this process which I've just talked about. And the virus that I'm talking about is just the influenza virus. So it's been looked at before, and the process as it has been shown before, does increase the risk of myocardial infarction in the setting of a viral attack. So that was the inflammatory response and how it affects the cardiovascular system. The virus, well, being a virus itself, can directly infect the cardiovascular system. The SARS-CoV-2 virus attaches to a receptor called the angiotensin converting enzyme receptor number 2. It latches on to the receptor. It then gets absorbed into the cell and internalized into the cell, and then the virus starts its own action, whereby it starts to replicate and take over the cell, and thereby killing the cell. So the ACE2 receptors are most common in the lungs, hence the primary manifestation of this disease, which is pneumonia. But the ACE2 receptors are also present in the heart and blood vessels. So the virus will get into the heart cell, damage the cellular machinery, and take it over completely, resulting in cell death. Again, I would like to say there's a precedent for viruses affecting heart cells, in this case, it is the SARS virus. The SARS virus in 2002 autopsy showed that viral genetic material was present in heart muscle cells. And also a recent case report from Italy underscored that the new coronavirus can also infect the heart, and in fact a bit worrying is that this can even happen after the acute phase of the infection, and it also has been shown to happen in the absence of lung disease. So this virus is pretty insidious. So we've discussed about how the virus can affect through inflammation, causing things like myocarditis, and inflammation can also affect plaques, thereby triggering a heart attack, and also the other method that it affects hearts by directly killing cells by entering into the myocardial cells. The third way that this virus can affect those with heart disease is that if you are severely ill with, let's say, a pneumonia, your lungs there will be not good enough oxygenation of the blood. That is called a mismatch between oxygen supply and demand. This would mean that the heart, which is already struggling, will be starved of oxygen. And if it is starved of oxygen, this can trigger a myocardial infarction or heart failure. So fever, for example, as well, fever and inflammation can accelerate the heart rate and increase the metabolic demands of the heart, right? This impaired gas exchange can further diminish oxygen supply to the heart muscle, thereby worsening the condition of a patient who has pre-existing heart disease. In Wuhan, again, out of the 72,000 patients, 22% of those who died had pre-existing cardiovascular disease. If you look at the different comorbidities, heart disease had the highest fatality rate at the rate of 10.5, which is higher than patients who just had diabetes, about 7%. Those with lung disease, in fact, had a lower case fatality rate than those with heart disease. So Professor Ritker of Brigham and Women's Hospital calls this COVID disease a very severe stress test for patients with heart disease. I would just like to move aside briefly to talk about venous thromboembolism, which has come up a lot in the news lately. In COVID, being a severe viral disease, and as we mentioned already, there's a lot of inflammatory chemicals released during the infection. This can also induce the liver to ramp up the production of important proteins to try to defend the body from infection. However, these proteins will make the blood more prone to clotting, while also reducing the secretion of natural clot-dissolving substances. So macroscopic VTE, venous thromboembolism, has been well described and occurs in up to 30% of COVID cases. However, microscopic clotting can also affect small blood vessels in the heart and other organs, such as the kidneys, setting up the stage for multi-system failure that can occur in the acute infection. So we've talked about inflammation, direct cell injury, and also just general stress, the lack of oxygen in a patient with heart disease. Let's talk about a few more things that are a bit more indirect. The treatment itself, the treatment that has been given, may have resulted in more injuries. In China, it was noted that given that the patients had fever, had an inflammatory response, medicines such as the non-steroidal anti-inflammatory drugs, antiviral drugs, glucocorticoids may have exacerbated the heart conditions of patients and resulted in fatal outcomes. So we know that non-steroidals may interact with other drugs and can increase a patient's blood pressure. They may interact with other drugs, blood pressure drugs, to make those blood pressure drugs less effective as well. Glucocorticoids raise blood glucose. the antiviral drugs that were used potentially could have caused arrhythmias and even myocardial weakness. I will talk about hydroxychloroquine in a later slide. Whatever it is, the treatment for COVID-19 is evolving very rapidly, and we have to just keep abreast of the latest medical therapy, but we need so much more evidence before we can arrive at what is the best treatment. So the multiple effects on the heart, they can cause myocarditis and heart failure, and thereby cardiogenic shock. The myocarditis can cause arrhythmias. In particular, it's been shown that atrial fibrillation is a fairly common occurrence. It can trigger heart attacks and acute coronary syndromes, and it can cause systemic venous thromboembolism. So those are the processes. So let's talk about the clinical aspects, a few more clinical aspects. So is the risk of getting severe COVID similar for all cardiac patients? I guess the answer is probably not. Those who are immune suppressed, such as cardiac transplant patients or patients with heart disease, and also who are getting treatment for cancer or leukemia, they would be at risk because they're immune suppressed. Those, as we said, those who have other comorbidities, especially being older or being pregnant, those heart patients will have more risk. The specific heart problems, heart conditions that may have higher risk compared to other heart problems would be especially heart failure and dilated cardiomyopathy. Those with congenital cyanotic heart disease also are at highest risk. Those with HOCM apparently are at risk as well, but there's no evidence to say that the virus can cause endocarditis, and the virus does not infect implanted devices such as pacemakers. What are the other indirect effects for heart patients? Well, one is that during this very severe pandemic, healthcare resources have been stretched. So patients may find the access to emergency treatment or even to regular treatment might be affected. It depends a lot on the local situation. Fortunately, to date, Malaysia has not been as badly affected. Other indirect effects are like, for example, the shortage of ventilators. Even a private hospital like ours, we had to help out by loaning our ventilators to the hospitals that have been treating COVID patients. And so there may have an indirect effect for heart patients. That means we sometimes occasionally may have to put off surgery, for example, because of the lack of ventilators. And also another obvious one is blood products. Blood products are now severely reduced because of the drop in donations, which is to be expected. And so these are indirect effects on patients, heart patients who do not have COVID disease. So, and patients themselves may delay seeking treatment out of fear of picking up the disease. I want to go into the final bit of the talk, which is about a little bit about the medications. As we mentioned earlier, the SARS-CoV-2 virus accesses cells through the ACE2 receptor. And there was an article linking the ACE inhibitor drugs and angiotensin receptor drugs with increased vulnerability to the SARS-CoV-2 virus, meaning that they think that in theory, the drugs can upscale, upregulate receptors, and therefore the SARS-CoV-2 virus has more ways to get into the cell. This is only a theory. It's not been borne out by any clinical studies. And so far as we can tell, there's no need to tell patients to stop medicines which are crucial for controlling their blood pressure. However, I do advise my patients who are on these drugs that should they be unfortunate and sustain the SARS-CoV-2 infection, to talk to the primary physician caring for them at that time as to whether to continue the drugs or not. So the information coming out about the SARS, about the ACE and ARB is still very, very early. As for another drug that's been in the news is hydroxychloroquine. To date, we don't see any clear advantage. There's a very large study that's just been launched to look at healthcare workers to see whether hydroxychloroquine reduces the risk of getting COVID-19. The worry we have, especially for heart patients, is that hydroxychloroquine can prolong the QT interval and result in a malignant cardiac arrhythmia. The QT interval is even more prolonged if hydroxychloroquine is used concurrently with macrolides, which was one of the suggestions for treatment of the COVID-2 in the beginning. So back to our local situation right here in Kuala Lumpur. CVSKL is a private cardiac hospital. How has this impacted us and our heart patients? Well, number one, we will, as a hospital, we are taking all the necessary precautions and reviewing these precautions very regularly. Our hospital is a cardiac and vascular hospital, so we do not primarily treat infections. To date, if there's anyone suspected of having COVID-19, we cannot treat this patient here. We will arrange for the patient to be treated in the appropriate hospital. Fortunately, we have not encountered that situation. For patients, just some information which might be relevant to when patients ask. All the patients who are admitted will be screened for SARS-CoV-2 with a PCR test. Practical information is that the test costs about 350 ringgit and it is not covered by most insurances at this time if the result is negative. For patients that are admitted, there is at the moment a slightly increased cost of treatment due to the use of masks and this personal protection equipment, which averages about 200 ringgit for each hospitalization. Having said that, our hospital is still continuing treatment as usual, as normal as the situation allows. So I wish all of you good health and to wish you all stay safe. I'm pleased that the methods, the measures that have been taken in our country have seemed to have worked as best as one can expect. And I hope we come out of this as soon as possible. Thank you.